Hello, everybody. This is Amy Rich. This is Boot Camp Day 5. This is going to cover healthcare provider professional reimbursement. And if you've been following along with our workouts, you just got through the cardio portion on day 4. You were running around trying to identify your workers' compensation patients that you've treated, verify their coverage, and find out where to send the bill, and then creating that perfect medical bill so that you can swing over to the swing challenge and learn healthcare provider professional reimbursement, what the carrier is going to swing back a check to you and how much that should be. So your learning objectives for today's presentation is we would like you to know how to calculate professional reimbursement. We're not going to be talking about facility reimbursement today. So we're focused in on professional reimbursement. That's doctor bills, physical therapist bills, radiology bills, that sort of thing. Also, our fee guidelines are based on Medicare payment policies. However, there are some exceptions. We would like you to know some of those exceptions to the Medicare payment policies during this presentation. Also, understand how to bill workers' comp specific services, including functional capacity evaluations, which generally speaking, they're separate from the Medicare medical fee guideline. So we'll get into that during this workout today on the swing set. So healthcare provider professional reimbursement. There's your EOB, and hopefully that's a swing back to you with a check to the healthcare provider and everything goes smooth. And also I'd like to cover our disclaimer, and that is we're doing our best to educate you here in these presentations, but as a system participant, that means employer, healthcare provider, insurance carrier, system participants are responsible for knowing all the laws and the rules, which are also known as the labor code and the administrative code, because if there's ever a disagreement or a complaint or a dispute, the division's going to use the actual words of the law and the rules. So that will help resolve any dispute. But we're doing our best to provide education to system participants during this workout today. The overview of the items that we're going to cover today are Chapter 134. Now, if you tuned in to day 4 with Patricia, she did a presentation on Chapter 133. If I were a healthcare provider, I would make sure my workers' comp staff know Chapter 133 and 134. 133 is how to submit your bills and what the carrier does, and Chapter 134 is all about the money, reimbursement. So Chapter 134 is called Benefits, Guidelines for Medical Services, Charges, and Payments. There's a lot of rules in that chapter. Specifically, we're going to cover the medical fee guideline for professional services. We're going to go through some reimbursement calculation examples. And as I said earlier, workers' comp specific services, some miscellaneous reimbursement rules, and then some of your resources like Comp Connection, where you can always call us if you have questions about this presentation or any other workers' compensation question. We'll give you that resource at the end of this presentation. So Chapter 134, it is divided up in these categories. If you were to go to R for rules, and that's on your interactive document, I will take you over there now. So on the second page of your interactive document, there's some important chapters and rules. As you see, Chapter 133, I was just talking about, and 134. You can just hop over there at any time. There's a lot of other links. So every word here, every sentence has a link. It's all interactive. So if you wanted to go to the web page, you can do that. Every single one of these is interactive. I would save it on my desktop so that I can get directly to places on our web page. Now, for some of you that are really in shape, workers' comp shape, you can go straight to our website and know where to find things. So let me go back to the presentation. If you went to our Chapter 134, you will know that it's divided up into these chapters. A is medical reimbursement policies, and miscellaneous reimbursement is B. C for our medical fee guidelines. And then if you are a facility out there attending or listening to this today, The health facility fee guidelines are all in subchapter E as an echo. And then our pharmaceutical benefits, which we're not going to cover today, is all found in chapter F. So if you want to know what pharmaceutical benefits are paid and how they're paid, go to subchapter F in chapter 134. Now, the Division of Workers' Compensation Fee Guidelines. When we write those rules, we ask for public input, we go through rulemaking activities, and we adopt them. And when we adopt them, they apply to non-network healthcare. That means treatment you're providing to a claim that's an injury that is not subject to a certified workers' compensation network. For those employers out there, you're the one that chooses to have coverage and that chooses to offer coverage through a network. If that's the case, there's a contract between a healthcare provider and the network. So our fee guidelines do not apply in that case unless your network contract says so. So again, our division fee guidelines apply to non-network healthcare and do not apply to healthcare for a certified workers' compensation network claim. There are exceptions, we always have exceptions, and that is designated doctor examinations for a network claim. They're not going to be paid according to the network contract. They're going to be paid according to our designated doctor exam rule. Our required medical exam, that's an RME doctor that's examining a patient. That's the insurance carrier's doctor. Those are paid out of our division fee guidelines, not according to the network contract. Now, if it's a network claim and they have to receive services outside of the network, maybe they need a super specialist and the network approves that, then our then our DWC fee guidelines would apply. Or your patient, like I'm work for the state, we have a network. If I got hurt and I went to an emergency room that wasn't part of the network, that's an exception and our fee guidelines would apply. So special approval and emergencies, and then pharmaceutical benefits are excluded from network contracts. So basically our fee guidelines apply to non-network healthcare. So non-network workers' compensation. Reimbursement for non-network healthcare shall be according to, and you'll see in each of those DWC fee guidelines, you're going to see these provisions. It says you're going to be paid according to this fee guideline unless you have a negotiated contract. And if neither of the two apply, then a fair and reasonable amount. So if there's no guideline for your service, perhaps you're a psychiatric facility. We don't have a fee guideline for psychiatric facility. Do you have a negotiated contract? And if you don't, then it's going to be a fair and reasonable amount. So look for a fee guideline that applies to your services. And then if you have a contract, that always supersedes any division fee guideline. And then if neither exist, there's no guideline for your healthcare service, and there's no contract, it would be a fair and reasonable amount. Now, our fee guidelines come up with amounts, and those amounts are called maximum allowable reimbursement amounts. That's the maximum amount that's going to be paid to a healthcare provider, and it should be consistent with the Labor Code 413.011 and our rules in the absence of a contract. So let's focus in on fair and reasonable. That's where we don't have a fee guideline that applies and there's no contract. So when you're trying to determine what is fair and reasonable, you're going to look to the Labor Code section 413.011. And in there, it has criteria for what the legislature thinks is fair and reasonable in our system. It doesn't give you dollar amounts. It gives you criteria. The first one is we want our injured employees to have quality medical care. So it has to be enough payment to ensure quality medical care is offered to our injured employees. The next thing is sometimes maybe perceived as conflicting is that it achieves effective medical cost control. So it's not paying too much. It's paying enough for quality care, but not too much, and does not provide for payment in excess of a fee that would be paid for someone, a patient of similar standard of living. So you have injured employees, they're employed. Are you looking to other patients that you have that have a similar standard of living, and what is paid for those patients? So again, this is all language from the statute. This is what the legislature said was fair and reasonable. We also have a rule that further explains fair and reasonable. And it's consistent with 413.011. And it says that the payment should ensure similar procedures provided in similar circumstances receive the same amount. So if you can compare a similar service in a similar circumstance and compare it, that would be good evidence to submit for fair and reasonable reimbursement. And it can be based on nationally recognized reimbursement studies, published DWC medical fee disputes. If you attend our training on medical fee dispute resolution, we teach you how to search for medical fee disputes, but it is on our website under M for medical fee disputes. You can look them up. Or values assigned for services involving similar work with resource commitments, if that's available. So that's all found in 134.1. When you've got a treatment or a HCPCS code or a service that doesn't have a fee guideline and doesn't have a contract, you're left with fair and reasonable. What is fair and reasonable reimbursement, and what is best practice in determining fair and reasonable? For healthcare providers and for you carriers out there, we suggest that you develop a rationale or a method that supports the amount you're seeking is fair and reasonable based on all the things I've just said. And put that position statement together that supports that your amount that you're seeking is consistent with 413.011 and that rule I was talking about. So use this information when healthcare provider and carrier, if you're negotiating before services are provided. Say you're a specialty facility like a psychiatric or a long-term care facility, you don't have a fee guideline and you don't have a contract, you can negotiate a contract up front. And we suggest that if there's no fee guideline and no contract. Or during reconsideration, have your position statement about what you think is fair and reasonable. Or if you have to go to medical fee dispute resolution, have that position statement. And also the carrier responding to a medical fee dispute should put together their methodology of how they came up with the amount they thought was fair and reasonable. So those are the exceptions. The fair and reasonable charges are the exceptions because we have fee guidelines and there's a lot of contracts out there. But if you come across one, this is what we suggest. Let's go into Chapter 134, specifically into the medical fee guideline for professional services. Remember, this is for non-network healthcare that you're providing. And in general, for you healthcare providers out there, 50% of new injuries are non-network, and 50% of injuries are associated and subject to a network. That's in today's world. So know that 50% of your claims that you're treating could be subject for professional reimbursement to 134.203. We'll go through that. So 134.203 was adopted and became effective for dates of service March 1st, 2008 and forward. It hasn't changed since. Now, the numbers within it have changed, and we'll explain that. But for dates of service March 1st, 2008 and forward, it is 134.203. So if you go to Chapter 134, you may see another fee guideline from before. Always look at the applicability section to know that it applies to your date of service. So this one is in place right now. And it covers professional services, and it does not include workers' comp specific services and programs. We'll go over those today. Prescription drugs and medicine, because there is a prescription pharmacy fee guideline out there in Chapter 134. It doesn't cover dental services. There is a fee guideline for dental services on our website in Chapter 134, or medical services provided through a network. Only those exceptions, emergencies and out-of-network approved services. These are the professional services we're talking about when we talk about the medical fee guideline. It's evaluation and management. Those are office visits. General medicine occurring in the office. PM&R, physical medicine and rehab. That's like physical therapy, occupational therapy, speech language therapy, radiology bills, pathology, anesthesiology, surgery performed in an office setting, and the professional services associated with a surgery. So that would be the doctor bill, not the facility bill. So anything, not anything billed on a HCFA, a CMS 1500, which oftentimes y'all call HCFA, but it's the professional part of the bill for a surgery. So that particular bill, I know ambulatory surgery centers bill on a CMS 1500. This rule does not apply to ASC or ambulatory surgery centers, even though they bill on a CMS 1500. It is the professional part of that episode of care. So the applicable payment policies for the medical fee guideline, we're going to use, and the rule says, use the Medicare payment policies for coding, billing, and reporting of these professional medical services. So way back when we first went to Medicare, we said, move your Medicare biller over next to your workers' comp biller, because they need to know everything about Medicare payment policies for professional services. Let me give you an idea. NCCI edits, National Correct Coding Initiative edits do apply in workers' compensation. The Medicare modifiers apply. Even the health professional shortage area provisions of the Medicare payment policies apply. And any other payment policies from Medicare apply. Now, there are exceptions we'll get into, but in general, if you're calling to ask if a Medicare payment policy applies, most of the time it does. We will go over some of those exceptions. Also, there's an incentive payment in addition to the HPSA areas for Medicare. If you're practicing and providing services in one of our underserved areas, there's an additional 10% that you are entitled to for those zip codes appearing in Rule 134.2. I believe Patricia's going to put that link to that rule in the chat right now. So if you're due a HPSA payment for Medicare and it's in the same zip code as our underserved area, you only get ours. You don't get both. So just a note for that. Now, any exceptions to the Medicare payment policies can be found in our rules and our statutes. So it's really all Medicare all the time, unless we say differently. And that's found in 134-203B. It says use Medicare payment policies. Let me give you some exceptions, some big exceptions to the Medicare payment policies. If you're a chiropractor's office, you know that Medicare does restrict what you can provide to Medicare patients. In our rule, we have the adjustment, if you will, not to play on chiropractic services, but there is a major adjustment in our statute that allows chiropractors to become treating doctors in our system. They can, and it doesn't restrict what they can do. They can practice within their scope and license. So Medicare does restrict a chiropractor providing services to a Medicare patient. In our law and rule, there's an exception. So chiropractors and workers' comp can practice within their license and scope, and they can be treating doctors. Now, Medicare changes all the time. You know that if you treat Medicare patients, their policies can change, not only at the beginning of the year, but during the year. Sometimes those policies come out and then they try to be retroactive. In our system, because of the language in A8 of 134-203, basically it's on the day they announce it. We don't go retroactive here in the workers' comp system. That's why this provision was written in there. So say, for instance, Medicare changes the conversion factor. It would be on the day they announce it and forward for us. Examples of Medicare payment policies that apply. We get calls in Comp Connection going, but what about this? Does this apply? Generally speaking, Medicare payment policies do apply. So some of the current examples that I wanted to point out to you are the MPPR, Medicare multiple procedure payment reduction. This is used for healthcare services provided by the same healthcare provider in the same day. This is a Medicare. It's a very sophisticated part of their fee guideline. It's part of ours too, because we adopt Medicare payment policies. So if you're providing always physical therapy services as designated by Medicare, yes, there's a reduction in multiple services. They will pay 100% of the highest practice expense, if you know that term, highest paid, if you will, service, and then a reduction after that. Same with surgery services. So if Medicare does it, we're doing it too. Also, the Medicare National Correct Coding Initiative. These have had different names in the past, bundling edits, if you want to call it that, column 1, column 2 edits. They can be found on the CMS website. I think Patricia's going to put in the chat a link to that, but you can go to CMS, Centers for Medicare and Medicaid Services.gov, and type in the search function NCCI physician edits. These are also called procedure to procedure, PTP edits now. And so they're saying if this CPT code is paired with this on your bill, some of them are bundled, some are not. Some can be appended with a 59 modifier, some cannot. Most of you have practice management software that's going to catch this before you send out a bill. But you'll need to know when a 59 is available to use or not. That's usually with your practice management software, or you can go to cms.gov and look it up. Also, something that's used in our system is a lot of physical therapy for our injured employees. The functional reporting modifiers that Medicare requires, we do too. The CQ and CO for physical therapy assistance and OT assistance. Yes, if Medicare requires it, so do we. So, and there's so many others. Also, remember, they're subject to change. So I've got these up here now, but I have a big asterisk down there. Medicare will change, and as they change, we do too. So keep an eye on your Medicare payment policies, sign up for those newsletters, and understand the Medicare payment policy changes throughout the year. Now, I've been saying it's all Medicare all the time, unless we say differently, and there are some that we want to point out. If our rule or our law conflicts with what Medicare says, ours will always take precedence. So remember that. Some examples of notable exceptions are in statute or labor code 408021. That is the statute that says our injured employees are entitled to all medically necessary care for the compensable injury. There is no cutoff. Even if they reach maximum medical improvement, they can still receive medically necessary care for the compensable injury. There is no date, there's no dollar amount. In Medicare, however, there is a dollar amount for physical therapy, for instance. It's a couple $1,000s for a Medicare beneficiary for a year. We don't have that cutoff. There's no threshold of monetary cap for physical therapy in our system. It has to be medically necessary, and it has to be for their compensable injury. So that's one example. Also, Medicare has another edit called medically unnecessary edits, restricting the number of units. We don't restrict number of units in our case. We have treatment guidelines and pre-authorization guidelines, but we don't restrict hard and fast. You can only have 5 of these every year or 5 of these during a session, not in the medical fee guideline. So those are some notable exceptions. The next one is that if your healthcare provider is licensed as a healthcare provider, they have to bill their own use their own license number. And that comes from what Patricia covered in day 4 is the rule 133.20, medical bill submission by healthcare provider. We say they have to, so if you're a physician assistant, you're licensed by the state of Texas or the state you're practicing in, you need to submit your own bill. You may not bill incident to. That's what Medicare allows in the Medicare system. Doctor sees the patient first, then the PA takes over and bills under the doctor's license number, that is not allowed in our system. So if you're some sort of physical therapist professional and you have a license, you need to bill under your own license number. The next notable conflict is that for those mid-levels, physician assistants and nurse practitioners, those are called non-physician practitioner reimbursement. We have a statute in the insurance code 1451-104 that says there's non-discriminatory payment or reimbursement for these type of professionals. I'm going to give you some examples of what this means, but it is a conflict with how Medicare calculates your reimbursement as a mid-level. There's a lesser of clause in the Medicare reimbursement policies as of today, and we don't use it because of this statute applies. So we've gone over Medicare payment policies and the exceptions. Now let's talk about what are you going to choose to put on your CMS 1500? What billing codes are you going to use? In 134.203, the medical fee guideline, little I, it says you must use current CPT codes and HCPCS codes. So they're all called HCPCS codes. Level 1 are CPT codes. Those are mostly services. And then level 2 HCPCS codes are things like DME items and items you would provide to a patient. So level 1 and level 2, you should be using 2024 books or resources to choose the code that best describes what you're providing to the injured employee. So this is on a CMS 1500. This is for professional services. Also, we have some specific CPT codes in our workers' comp specific rules in Chapter 134. We give you the codes in those rules. And note that I say use the 2024 codes. There is an exception. We've adopted case management codes, and they're from a few years back. AMA, which is the American Medical Association, had deleted them, but we kept them. Because they're in our rule, you can still use them. And I will go over that in detail later in the presentation. We want to make a special note here. Oftentimes we get calls in Comp Connection that say, we've billed out 99215. That's an advanced evaluation and management or office visit. And the carrier questioned it and want us to down code and choose another code. A couple of comments about that. One is, if you choose to change the code, it's up to you. It's your business decision. You have to do that within 95 days because it's considered a new bill or another bill, if you will, and the 95 days will be applied. So keep up with that, make your decisions fast, and make sure your documentation matches your choice of E&M service. So this is a common problem in workers' compensation. Now, Medicare, because we're based on Medicare, Medicare changed some of the documentation and the selection of code policies for E&M codes, evaluation and management. Those are office visit codes. Medicare says you're going to be choosing code based on one of two criteria. One is your level of medical decision-making, regardless of the time spent with the patient. So that's MDM, or total time spent with the injured employee or the Medicare beneficiary for the Medicare. We're using Medicare, so both cases. So are you going to choose one or the other? If you want to learn more about this, I've got a couple of citations here, and Patricia's going to put a link in the chat also. But the AMA, American Medical Association, creates the CPT code level 1. They create the description, and they also can give you information and education on the descriptors and guidelines for selection of your E&M codes. Also from cms.gov, there is a guide there. I have the MLN Med Learn Matters document for you to look that up. So cms.gov should also be one of your favorites in your URL favorite section because we lean on Medicare. All right, some examples of reimbursement calculations from 134.203. If you remember, 134.203 has service categories: E&M codes, general medicine, PM&R, radiology, pathology, anesthesiology, surgery. Say your doctor does surgery in the office, that's in an office setting, or surgery while your patient is in a facility. Those bills are professional bills, and the MAR, or the maximum allowable reimbursement, can be calculated through 134.203. We use the Medicare payment policies, remember? And that includes a very sophisticated way of assigning a value, a relative value to that service. So if you want to know the long calculation from Medicare, we've got it right here for you. Now, you probably have software that calculates this out, or someone's created a spreadsheet for this. But if you want to know the long calculation for Medicare's reimbursement methodology, it's right here. So they are looking at every part of the cost that it provides, that it takes to provide services to a Medicare beneficiary. And because we adopted it, so are we. So they're going to look at your work expense times what they call a GPCI. And that is a geographic practice cost index. So depending on where you are in Texas, there's going to be a different GPCI for you. There's 8 different GPCIs in Texas for professional services. Practice expense times a PE GPCI, so it is adjusted per your location. Malpractice expense, and then again adjusted for your location, and that equals an RVU, relative value unit. That's how Medicare does it. And then the last thing they do, and you'll hear talk about this, is they develop a conversion factor every year. That's a dollar amount. So the RVU times the conversion factor from CMS equals Medicare's reimbursement amount that comes to you. So again, depending on where you are in the state, there's a different amount. There's 8 different locations. If you don't find your location, there's the 8th one is the rest of Texas. So that's how Medicare does it. So we have modifications. The law said adopt a standardized system. We did by using Medicare payment policies, but the law also says we can make adjustments or modifications. So in this, we do it in a big way. And that is we replace the Medicare conversion factor with the Division of Workers' Compensation conversion factor in that calculation I just showed you. The DWC conversion factors are found on our website, and they are based on the Medicare Economic Index, or MEI, if you will. So that MEI is based on the cost and goods of services to be provided. So I'll show you on the next slide. On the left, this is just a screenshot from C, from conversion factors, workers' comp A through Z. If you go to C for conversion factors, you're going to see this table. On the left are dates that it applies to. So they're calendar year. So every year we come up with our next row of new conversion factors. You'll see what we've done all the way back to 2019. On the right, on that far column on the right, those are the increases you have experienced in professional fee guideline reimbursement over the years. This year is the biggest increase ever. So for in-office procedures, it's $67.81. That's good. Also, for those services where your doctor is doing surgery while the patient's in a facility, we're going to pay even higher. $85.12 is our dollar conversion factor. I'll show you how to do the math and come up with a percentage over Medicare. But I'll tell you right now, the $67.81 is 204% of Medicare, and the $85.12 is 255% of what Medicare pays. Because we adopt a higher conversion factor, it's based on the MEI, which is the cost of goods and services, and this is the largest increase you've experienced yet. If you see, we've been doing this since 2008, and it's only gone up. Maybe smaller percentages, but it's only gone up. since I've been around, and we adopted the Medicare payment policies. Let's go and compare Medicare's reimbursement calculation with the Division of Workers' Compensation calculation. These methodologies are compared here. And if you see, both Medicare and DWC have the same calculation adjusted for gypsies, the work, the practice, and the malpractice, all adjusted for your area. That comes up with a total RVU. On the Medicare side, they're using their Medicare conversion factor. And on ours, you replace it with our conversion factor. And our conversion factor changes once a year. Medicare can actually change theirs during the year, and that happened this year in 2024 in March. So that is our modification to the long calculation. And let me give you an example here. This is a long calculation example for those of you that want to do this math. Again, there's a shortcut to this I'm going to show you, but the long way, just to understand how we come up with this. This is a 99214 that was billed in Austin, Texas. Remember, they're geographically adjusted. So these are the numbers I've plugged in for Medicare and for DWC. They stay the same until you get to the conversion factor. Medicare's conversion factor for 2024 is $33.28. Ours is $67.81 for office visits. I'm going to just jump over to the internet real quick and show you where I got all of these numbers. Our Medicare administrative contractor is Novitas-Solutions. We're jurisdiction JH. And right here is the fee schedule for Medicare, not us, but for Medicare. And we use these numbers in that long calculation. So in this example, I did 99214. I'm going to use today's date of service. We're in Texas. The locality is Austin. See that rest of state is here too, and all of these gypsies. Austin. I'm going to hit search. If you scroll down Novitas, you're going to see all of these numbers in here, where I got all my numbers. Plug into that calculation. Here is their conversion factor, $33.28 here. So if you're interested in doing the long calculation, this is where you get all your factors. This is their participating provider amount. That's what we use. If you're doing the short calculation, you would multiply that times our percentage, and I'll give you that shortcut next. But this is a Novitas website. So it's Novitas or novitas-solutions.com into their fee schedules for professional. It's a physician fee schedule amount. This is Medicare's administrative contractor for the state of Texas. Let me go back to our presentation. Okay, so that's where I got all those factors. And you see it's 130.50 for the Medicare amount, and ours is, because we replaced $67.81, it's $265 is what you're getting paid for that. It's good pay for workers' comp in Texas. Now, if you're not interested in doing the long calculation, here's the shortcut. Now, we have two conversion factors, one for surgery, one for professional services in the office. That $67.81 is for the one in the office. So you would take ours divided by theirs, and that equals your percentage. So every year people call us at the beginning of the year going, where's the fee guideline? Where is it printed on your website? We do not have a list of CPT codes and amounts on our website. What you do is you go to the Medicare website and get their conversion factor. You go to our website, get our conversion factor, and take ours divided by theirs equals a percentage. After that, you just take the Medicare fee guideline and just multiply it times 2.04 for all the categories that $67.81 applies to. So that is the approximate amount of our MAR, our DWC reimbursement for professional services. If you're doing the shortcut, there can be some cents off here and there, but if you're looking for a shortcut, that's the way to do it. So let's take the 99214 and do the short calculation example. This was done in Austin, Texas. So you take our conversion factor divided by theirs times the participating amount equals our MAR. 6781 divided by 33.28 times the participating amount. I showed you that, where to look in the Novitas Dash solution. That's $130.50, and that equals 265.84. That's the shortcut if you want to know. So if you're calling us in January, we usually do a presentation in January to talk about the new conversion factors, both with Medicare and with us. But note, Medicare changes things. We try to keep an eye on that. You should too, by using the Novitas Dash Solutions website to see if Medicare changes. If they change, we change on the day they change and going forward. So these are approximate amounts if you're doing it the shortcut way. Now let's get into PAs and NPs, or physician assistants, nurse practitioners. Remember that there's a special exception here. The reimbursement for these type of professionals is coming from 134.203 and labor code 413.011 that refers to the insurance code 1451.104. Remember the non-discriminatory section of the insurance code. It's the labor code plus the insurance code put together. So in this case, I wanted to point it out because we have, and we know and understand that there's a lot of PAs and NPs out there taking care of our injured employees. We wanted to go over these specifically. In the 1451, it's called non-discriminatory payment or reimbursement. So it allows for different amount of payment or reimbursement for these type of professionals, but only if the methodology used to compute the amount is the same methodology used to compute the amount of payment for the doctor. So I know that's really nuanced, but it does make a difference for your PAs and NPs. And let me illustrate. Reimbursements for PAs and nurse practitioners in the Medicare Claims Processing Manual is found in Chapter 12. You can go to cms.gov. In the Medicare system, PAs and NP services are paid at one or the other. Lesser of 80% of the actual charge or 85% of what the doctor, physician in this case, is paid under the Medicare physician fee schedule. So that's a decision, that's an either or, and they're taking the lesser of. We don't do that. That's in conflict with 1451.104. So this conflicts with the insurance code, and the 85% of what a physician is paid does not conflict because it's the same reimbursement methodology that a physician is using. 80% of a lesser charge does conflict because it's not the same way a doctor is paid. So we're going to be using the second criteria that Medicare uses. So this is a great example of where it's all Medicare all the time, unless we say different, and it was outlined in the labor code that's different and it conflicts. Ours will take precedence. So if your PA is performing assist at surgery services in the Medicare Claims Processing Manual, it says also 80% of the lesser of the actual charge or 85% of what a physician is paid under the Medicare system. This part conflicts because it's not the same as how your doctors are paid, or physicians in this case. So if it's assist at surgery, physicians are paid at 16% of the surgical amount. PAs receive 13.6% of the amount paid to physicians for assist at surgery services. And you need to append with the Medicare modifier, which is AS modifier, if you're billing PA assisted surgery services. So just remember that first part, we're just taking that bullet out and we're going to go with how Medicare pays your physician, and then you get a percent of that for assisted surgery. So just to know that we've had several disputes. If you ever wanted to look up a medical fee dispute about this, we quote these statutes and these rules. So reimbursements for PAs and nurse practitioners. Reimbursing a PA at 80% of the actual charge is not the same methodology as a physician, just to drive this home because it conflicts. And so you're going to get 85% and 85% of the 16% for assisted surgery services. Yeah. Here is a calculation for that. Let's take 99213. This is not assisted surgery. This is an office visit conducted by a PA or an NP in Austin, Texas. I just gave you the steps there to find this out and use the short calculation. So the conversion factor for an office visit for 2004 is 67.81. Find that first as your step one. Then find your Medicare conversion factor, which happens to be $33.28. Take ours, divide it by theirs. That's 204%. The locality is Austin. Find the Medicare participating amount for 99213, which happens to be $92.63. That's if you're billing your bill directly to Medicare, which you're not, because this is workers' comp. You're billing your bill to the work comp carrier, and you're going to get 85% of that times 204%. So I hope that makes sense to you. We're just not using the 80% of your charge. We're going to calculate it using the same as a physician fee schedule. And remember, PAs and NPs out there, you are billing under your license number. There is no incident to billing. So the carrier should be able to recognize that and apply this methodology to your reimbursement. There are other categories within the medical fee guideline. If you're wondering how much you get paid for a HCPCS code, remember those are things, and they're usually start with an alpha character, A, E, J, K, and L. If you have a HCPCS code that is starts with A, E, J, K, or L, you're going to look to the Medicare's DMEPOS fee schedule. That's durable medical equipment, prosthetics, orthotics, and supplies. You'll get 125% of that. That 125% is static. It hasn't changed since 2008. So as Medicare changes, we're paying the 25% more. So Medicare adjusts the DMEPOS, we're going to pay you 25% more. Now, if Medicare has no published Medicare rate for your HCPCS code, then you look to the Medicaid fee schedule. Does the Medicaid fee schedule have an amount for that HCPCS code? And if there is no published amount by Medicare or Medicaid, then the fair and reasonable may apply. One good example for this is hearing aids. Medicare doesn't pay because it's a statutory exclusion for for hearing aids. You may look to Medicaid. If there's no fee for your HCPCS, then it's fair and reasonable. And we have that best practice slide earlier in the presentation for you to demonstrate what you think is fair and reasonable, both on the carrier side and the healthcare provider or the hearing aid fitter side or audiologist side. CMS Medicare payment policies and physician fee schedules. I've navigated over there to Novitas, but CMS is the mother company, if you will. CMS hires Novitas, and there's several other Medicare administrative contractors out there. Texas happens to have Novitas. So here's the link for cms.gov, and you can find the Medicare physician fee schedule with all those numbers if you want to do the long calculation and find out the participating amount to multiply times your percentage, all here. So if you're calling us in January, February, looking for the fee schedule, we're going to point you to CMS, get those numbers, and then multiply times our index over Medicare. The Medicaid fee schedules can be found at tmhp.com. And I'm going to show you that real quick. I'm on the Novitas, but I'm going to go to the Medicaid fee schedule. Medicaid is run state by state. So this company, TMHP, pays bills for Medicaid in Texas. This is where you're going to go for the fee schedules. That link on your slide also takes you there. We go to the static fee schedules here. my computer is thinking about that, but right here in static fee schedules, that's where you're going to go. And there are a lot of Excel spreadsheets. So you see here. So if any of our fee guidelines say use Medicaid, this is where you go. Go back to our presentation. Now, there are a lot of resources for the medical fee guideline. We have a set of frequently asked questions, and it talks about all kinds of things. And I'm going to get you over there right now. So here's our website. Now you have a wayfinding PDF interactive document that'll help you get to these places. But if you're just getting to tdi.texas.gov, the first thing you're going to do is click on workers' compensation. That's all us, because TDI is large and they govern and regulate all kinds of insurance. Workers' comp is just one division in the TDI. So you're going to click here. You see this A through Z right here? That's not what we want you to use. We want you to use this A through Z right here, just FYI. So also, our healthcare provider webpage has changed recently if you haven't seen it. We have 9 little doors or tiles, if you will, starting with Comp Connection, what's new if you want to sign up for our e-news, how to become a Texas healthcare provider. So if you're new to workers' comp, there is a checklist right here to become a treating doctor right here. That's new. Coverage verification, pre-auth, which is our next boot camp, medical billing, everything Patricia covered, and how to navigate denials, which we will talk about in September. Medical fee guidelines and information. This is your medical fee guideline page. So if you're a hospital out there, here's your hospital fee guidelines, but also the medical fee guidelines, which we've been talking about. All of them are listed there, and the frequently asked questions are right here. So I'll just go to them. Some great frequently asked questions. So if you haven't been here, this is where it lives. Let me go back to the presentation. There's special calculation for anesthesia. By the way, if you're anesthesiology group out there, we're using our 2 conversion factors. I know Medicare has multiple conversion factors for anesthesia. You're going to use the 67.81 for 2004. So take a look at the FAQs. They're a great resource for you, or call Comp Connection. Now, to leave the medical fee guideline, we're going to go into the rest of those professional services, workers' comp specific services, 134.209 to 134.230. I am not covering today the designated doctor and referral doctor and required medical exam doctor, MMI, maximum medical improvement, and impairment rating, and similar type of exams today. There's a recording on our website that talks about that. We're going to talk about the other workers' comp specific services here. So generally speaking, once we get out of the medical fee guideline, we have our own workers' comp specific rules. Generally, they give you descriptions of the services and the actual CPT codes and the modifiers we want you to use and the reimbursement amounts in these specifics. So if someone calls looking for those CPT codes and those amounts, we do have them on our website. But the majority of your professional services are covered by the medical fee guideline, and you're going to have to use CMS or Medicare and their administrative contractors. So in 134.209, this is the applicability rule. And in there, it states that these rules do not apply to professional services covered by 203. We've talked about those. And pharmacy items. We have our own pharmacy fee guideline. So look at that if you're looking for pharmacy reimbursement. Hospital services, go to the facility fee guideline. Services provided through a network, those are provided through contract unless it meets those exceptions. There are miscellaneous exceptions. So also 134.210 includes the coding, billing, and reporting for workers' comp specific codes, which services are paid with the incentive payment and the modifiers. So you'll find that in 134.210, all the modifiers that are work comp specific are found in there. and 134.210. If you are happen to be a home health service, they're not covered by 134.203. It is for licensed home health agencies that are billing services in the state of Texas. 134.215 applies to you. And as I showed you, the Texas Medicaid Health Partners, TMHP.com, you will find your home health fee schedule there, and we're paying 25% of that. 25% over that, 125% of what Texas Medicaid fee schedule. So that's our own rule. It's very short, and 134.215 if you're a home health agency. Now let's talk about case management services. This is important to the workers' comp system. It is out there to help pay a treating doctor or referral doctor money so that they can help coordinate medical care and also return our injured employees back to the workplace as soon as it's medically safe and appropriate. So if you're coordinating some of that, know that there's some reimbursement out there for you. This applies to treating doctors and referral doctors. There are CPT codes in this rule. Modifiers and the reimbursement amounts are found in the rule. It includes team conferences, telephone calls with outside interdisciplinary teams. The CPT codes are listed right there, 99361 all the way 99373. These are CPT codes that were active in 2007, but they were deleted by the American Medical Association. However, because we name them in the rule, they are still active in our system. So this is the exception to always use the current CPT code or HCPCS code. In this case, you can look to these codes in this rule to find out if your doctor is providing that service and helping get people back to work and meeting with outside people. You could possibly bill and be reimbursed for that. If you choose a CPT code, one of these CPT codes, your documentation has to support that that's actually what your doctor did. The descriptions, because you're not going to find them in the 2024 AMA CPT code book, the descriptions can be found on our website under medical fee guideline question FAQ number 7. Remember, I showed you how to get there on our website. If you go to M in the workers' comp, A through Z, M is medical fee guideline. You would just scroll down to the FAQs and go to question number 7. And there is a link on our slide here. So you can find out what 99361 is, 62, 71, 72, and 73, and see if your doctor's providing that. Let's use an example. 99362. They also provide modifiers in that rule with a W1 modifier. This is the description for 99362 is medical conference by a physician with an interdisciplinary team of health professionals or representative of community agencies to coordinate activities of patient care. Patient's not there, and it's a 60-minute event. The reimbursement for your treating doctor would be 99362 W1. You would get $198. That amount is not subject to increases over the years. It is static. It is in the fee guideline and named. The contributing healthcare provider can get a $50, and there's no modifier for the contributing healthcare provider. So that's just one example of what's out there available to you. We put a lot of emphasis on helping injured employees get back to the workplace and get the right care. So know that case management codes are out there for you to use. The next workers' comp specific rule that I'm talking about is 134.225. This covers functional capacity evaluations. Know that this rule says that only 3 FCEs are allowed per claim. This is where we do put a limit on it, but it's spelled out in the rules. Also, the CPT code for FCEs is 97750. You're going to append with an FC. Now, because this 97,000 series code also is in the Medicare world requires some other modifiers, I would use those other modifiers like GPG angio because 134.203 is referenced in this rule. When you go to 134.203, it says use Medicare payment policies. So make sure that you use 99750 FC, and there's only 3 FCs allowed per claim. If the Division of Workers' Compensation orders an FCE, that does not count towards the 3. So if you're a doctor conducting an FCE, you need to know if that claimant has had more than 3 or up to 3. These are billed per hour with a maximum of 4 hours for the initial test, maximum of 2 hours for the interim test, and a maximum of 3 hours for the discharge test. So know that all of that documentation needs to be there. If you're billing 97750 and you choose one of those, the hours, look at the rule 134.225. Look at all the details in the rule and all elements that are required for a functional capacity evaluation. Your documentation needs to show that your healthcare professional did all of the elements that were required for an FC in order for it to have no problems swinging back to you with a payment. The next rule in our workers' comp specific services is 134.230. These are our return to work rehabilitation programs and includes work hardening, work conditioning, chronic pain management programs, outpatient medical rehab programs. This rule outlines all of those programs and what the reimbursement is. And if you're conducting these types of services, accreditation by a CARF is recommended but not required. CPT codes and modifiers are listed and billed per hour. Take a look at 134.230 and every word of that rule if you're trying to bill out return to work rehabilitation programs. Let's get into miscellaneous reimbursement. That's in subchapter B in chapter 134. 134.100. If your treating doctor is going to attend an RME or a required medical exam doctor, this is the insurance carrier's doctor, and wants reimbursement for attendance, look at 134.100. It's going to tell you how to bill that. 134.110 is reimbursement for an injured employee for travel expenses incurred. So if you have an injured employee you're working with, you want to tell them about this rule. And also they can call customer service and help them through asking for reimbursement on travel expenses incurred. Also, miscellaneous reimbursements includes reimbursement for medical documentation. That's one of the most frequented rules in the workers' comp specific services. So 134.120 covers reimbursement to you, the doctors out there, or the healthcare professionals that are supplying medical records. The insurance carrier is not required to reimburse the initial copy of medical records. If our rules say that you need to send it, you send it. You can't charge for that. You're not entitled to reimbursement for that. Also, if the injured employee or their representative asks for a copy of medical records, the first copy can go to them with no charge. The requester must reimburse for subsequent copies. So, injured employee gets a copy free, and the insurance carrier gets a copy. If our rules require you to send it with the bill, that you don't get reimbursement for that. You'll get reimbursement for the services, but not for the medical records. So if they ask for subsequent copies, you can charge. Reimbursement amounts are found in this rule 134.120. This is slide 58, and we're talking about when there's reimbursement for records provided to the Office of Injured Employee Counsel. That's a separate state agency that provides assistance to your injured employees that are going through dispute resolution. Sometimes they're going to ask for information. So in 28 TAC, Part 6, this is on the Office of Injured Employee Counsel's website. I think Patricia's going to put a link in there. Their Texas Administrative Code 276.11 says a healthcare provider's reimbursement from an insurance carrier for costs of documentations provided to OIC are prescribed by the provisions of 134.120. So know that that exists and that you can get reimbursement according to 134.120. If you're providing records to a designated doctor, so your injured employee is going to have an appointment with a designated doctor. That treating doctor may be reimbursed by the insurance carrier for the cost of copying that injured employee's medical records, and you're going to send it over to the designated doctor. That's found, the reimbursement for that is found in 134.120, reimbursement for medical record documentation. Now, here is a topic we haven't talked about a lot in the past, but there is the rule 134.130, interest for late payment on medical bills and refunds. This is interesting. Insurance carriers must pay interest on medical bills that are paid on or after the 60th day. That means they're late after the insurance carrier originally received a complete medical bill. Remember, your bill has to be perfect as you're swinging it over to the carrier, and they're going to swing back, hopefully, a payment. Get your coding, your modifiers, everything correct in that way. If they're paying on or after the 60th day, they may owe you interest. Also, for refunds, if you get a request for a healthcare provider for a refund from the insurance carrier, and you're paying that back to the insurance carrier later than the 60th day after you receive that request, you could owe interest to the insurance carrier. The interest rate, the percentage, if you will, is determined according to the Labor Code 401.023. And we publish those interest rates quarterly. How to calculate the interest? You're going to multiply the interest rate by the amount that's due to determine the annual amount of interest. Divide the annual amount by 365, which is how many days in a year, to determine the daily interest amount, and then multiply that daily interest amount by the number of days the interest is owed. Now that sounds complicated, so we have a table out there on our website that helps you calculate this. The interest rates are published and the calculator is out there. I'm going to take you over there now. So we're back to the workers' comp. Remember, we're on their website here. Do not use this A through Z. Use this one down here. This is us. I for interest rates is what you're going to choose. Here it is, interest rates. Here are the rates. Remember, they're published quarterly. We're at 8.57%. Hit the back button, and you can go to the calculator here. So remember, I for interest rate, and also you have the links on your slide here. So if you go to the calculator, the Excel calculator, and it has to download. I'm going to download this file. Here is this file. We have 3 tabs on this Excel spreadsheet. Instructions are first. So if you want to know what's going on these calculations, not just for medical bills or refunds, it's for all kinds of payments in the workers' comp system. So here are the instructions. Here are the interest rates on the last tab and the simple interest calculation here. This is, you need to scroll all the way over to medical bills. Medical payments. So this is where you're going to put in when the bill was received, when they actually paid. It's going to start putting in amounts here for you, and you're going to know the interest rate. So this is your calculator. If you have any questions, the instructions on the first tab. That's out there. If you've never used that, it's a great tool for you guys to use and know how much interest is owed. Now we're at the point where I am going to do a little strength test. We're going to flex your knowledge. Did I train your brain or not? So we're going to implement a polling question here. Now, there are 5 questions here. The first question is, in calculating the Division of Workers' Compensation non-network professional fees, you should replace the Medicare conversion factor with the Division of Workers' Compensation conversion factor in the Medicare calculation. That answer is true. That is our modification to that long calculation, is we always have our own conversion factors So that's the answer to number one. Number two, is incident to billing allowed for workers' compensation system for licensed mid-levels like PAs and NPs? The answer is no. You should always bill under your license number, not the doctor's number. So if you're a mid-level or if you're any licensed healthcare provider, you need to bill under your license number. Number three, does Medicare's payment policy for the MPPR, multiple procedure payment reduction, apply to Texas workers' compensation system for non-network PT services? And the answer is yes, Medicare does it. We do it too. Also, is there a monetary cap? Meaning, do we have like a dollar amount? We say only our injured employees only get X number of dollars, just like Medicare. The answer is no. Medically necessary services for the life of the claim for the compensable injury. The answer is no. How many FCEs are allowed per claim, not including the DWC ordered FCEs? Most of you got it right. It is 3. Thank you for participating in these questions. I'll stop sharing now. Let's review what we've gone over. Chapter 134, all of those subchapters in there, and we focus specifically on the medical fee guideline for professional services, some reimbursement calculation examples, workers' comp specific services, some miscellaneous reimbursement opportunities out there, and your resources. Next time, as we make our way through the workers' compensation obstacle course, we're going to go over to this climbing net, and we don't want you to fall through those holes. We're going to talk about pre-authorization, medical necessity, and utilization review. Your learning objectives for the next boot camp are to determine what medical services require pre-authorization, know the steps to request pre-auth, and understand how to appeal pre-authorization is your next boot camp topic. If you have any questions on today's topic or any others, please contact us at Comp Connection. You can call us, and if you need to email us, it's compconnection@tdi.texas.gov. Thank you so much for attending today's webinar and watching.